Good afternoon. My name is Leah, and I will be discussing the current policy for CMS penalties for healthcare-associated infections as part of the value-based purchasing program, as well as proposed amendments to the measurement metrics and enforcement. Currently, CMS withholds 2% of payments as reimbursement for all healthcare organizations each year. Organizations have the opportunity to earn back these payments based on selected indicators by just demonstrating high achievement or improvement in the 4 areas outlined: experience of care, clinical care, safety, and the efficiency and cost reduction for each patient. Payment year 2019, these patient indicators are actually reflected in 2017 and 2018. The current value-based purchasing program metrics and enforcement utilize these measurement metrics that are not validated and are also not widely used across government agencies. For example, the measurement metric that CMS uses for CLABSI and CAUTI is not the same measurement metric that the CDC uses for these conditions. Also, they utilize old data. The 2013 to 2016 data is what is being utilized for payment year 2020. Finally, the current policy and procedure with enforcement penalizes struggling organizations without providing any assistance for improvement or mentoring for best practice. As part of the proposed policy changes, performance metrics must be measured in ways that include demographic data, comorbidities to reflect the actual level of care the patient requires, as well as socioeconomic challenges because all of these measures impact patient outcomes. Further, metrics must be measured with validated tools that are standardized across federal agencies. And finally, CMS must identify and evaluate low-achieving organizations and invest in the struggling organizations rather than further penalizing them to assist with true quality improvement rather than implementing punitive measures. For example, if a struggling organization is further penalized, they are less likely to improve and actually more likely to have greater penalization in the following years. The economic impact of these policy changes would be demonstrated by utilizing validated metrics. There would not be a change from this current practice, as CMS already measures using metrics. However, it would be an improvement because it would be both more accurate as well as more standardized across governmental organizations. By modifying the value-based purchasing program, it would be an economic impact because the current program is budget neutral. However, the value could be recouped in demonstrating improved patient outcomes. Increasing resources presents a political barrier, particularly in times of increasing national debt. However, we could see an improvement in patient outcomes. Quality outcomes are the most important factor to consider. Improving our data accuracy and the validity of our measurement tools serves to improve the program's measurement metrics and provide a more accurate picture of how organizations are actually doing. Are they preventing new infections from recurring, or is the measurement metric either detecting more infections or not enough infections? A standardized process, particularly across government organizations, would help with this. Finally, investing resources in struggling organizations in the form of mentoring by organizations that are achieving, or in terms of providing more resources, funding, and performance improvement plans would improve the patient outcomes, safety, satisfaction, and efficiency, which are the measures that these organizations are actually judged on, and will also improve population health and reduce health disparities. We find that often patients with the most comorbidities are the most expensive to care for, but they're also the patients who are facing the greatest socioeconomic and demographic barriers. By providing resources to the organizations who spend the most time caring for these patients, we can truly make an impact on population health. As a call to action, we need to see true improvements in population health. CMS must invest its resources and expertise in the organizations that struggle at most. Only when all organizations have resources needed to implement evidence-based practice improvement changes and improve their outcomes will the value-based purchasing program be a fair and accurate of healthcare quality. By improving measurement metrics and investing in underachieving organizations, the ACA Value-Based Purchasing Program will advance its goal of improving patient outcomes, safety, satisfaction, and efficiency for the entire population. I encourage you to refer to the handout accompanying this organization for further information and ways to improve the measurement metrics, and to also participate in the CMS comment period related to value-based purchasing modifications. For further questions, please see the references attached. Thank you for your time, and thank you for listening.